Have you heard the
Could you summarize the case, please?
Excuse me?
Could you please tell what the case is about?
Do you hear me, Professor Fauzi?
Yes, we can hear you. Yes.
We have is invading into the liver and invading porta hepatis with total encasement of the hepatic artery. Patient have obstructive jaundice, a trial of ERCP, despite cannulation, failed to pass the advanced structure, not visualized even by injection of dye, total complete obstruction with failure to pass into the common hepatic duct into the liver. So we have the last combo case. We are going to do EUS guided biliary drainage. We are going to take biopsy by using FMD from the mass itself. I'm here working from Mansoura University. I am assisted with Dr. Asma and our nurses Shaima and Dalia. Before we go live, we started injection from the left loop of the liver. As we see in the fluoroscopic image, do you see the fluoroscopic image?
Not yet. So please fluoro.
You see the fluoro?
No, not yet.
Okay, it will be here in a second.
Okay, we have it. We have it.
Okay, we have this fluoroscopic image. We started by injection into the left hepatic duct. We tried to manipulate the wire into the common hepatic duct, but we failed to pass the structure. So as we see, we have markedly dilated left system. We performed dilation with 7 French cystotome. 7 French cystotome is now in place, and after dilation of tract, we are going to perform hepatogastrostomy by inserting partially covered 8 cm Boston biliary stent. So we are going now to exchange the cystotome, keeping the wire in place. Is the fluoroscopic image clear?
Very clear. So this is one of the most challenging procedures in EUS, is hepatogastrostomy. So I'm not keep asking you a lot of things because you need total focus with your team. Okay, so please take your time and do it nicely. I'm sure that's going to be a very nice demonstration. So understand that under US guidance, you have punctured the left lobe, use a 19-gauge needle, and then inserted a 035 guide wire, and then over the guide wire, use a 7 French cystotome to create a fistula to communicate the stomach and the left system. So now you just remove the cystotome and you're gonna insert a 10 centimeter long,
8 centimeters,
8 centimeter long, partially covered biliary stent from Boston Scientific, wall flex stent. Okay.
Yes.
So please take your time.
And already have a PTD in the right system, but the PTD is complicated with cholangitis, white blood cell elevated to 22, and the patient had recurrent fever despite being on antibiotic. So if we succeed, we try to see the right system, but there is no bridging between the right and left system. So at the start, we will drain the left one, hoping for the next step to remove totally the PTD to avoid the complication of the PTD from recurrent infection and repeated cholangitis for the patient.
Okay, so this is a very indication for hepatogastrostomy.
Yes, now we are following under fluoroscopic guidance through the left system. Okay, at this moment we are straight in the left system. We can see the distal mark of the stent. Now at this moment we can shift to the endoscopic view. To see our stent in better position, because the last step for stent deployment is usually under endoscopic guidance, assisted with fluoroscopic guidance. Now you can see the endoscopic view of the stomach.
Yes.
Now we have the stent. We can leave it in the long position, so we can see actually the distal release of the stent. Now we have the distal part of the stent seen at this part. Do you see it? Okay. Now we can start deployment under endoscopic and fluoroscopic guidance. I will ask my assistant to slowly open the stent. Okay, wait a moment. Okay, open. I'm شايف أي movement منك صح؟ Open it in, أيوة. Okay, we start now deployment. Do you see opening of the stent gradually?
Yes.
Okay, we will now stop and check our position fluoroscopic and endoscopic. Okay, we will little bit pull inside. We should leave a longer part inside the stomach. Fear of stent migration, so I will pull a little bit back and try to be in a longer position. Now I will ask my assistant to gradually open again the stent. Stop. I will recheck my position again. Okay. Now reopen slowly. Now we can see the stent opening inside the stomach, leaving a longer part inside the stomach with a good bile drain now. You can see the view endoscopic and fluoroscopic.
Very nice demonstration. Congratulations, Dr.
Now we can see adequate bile drain, and we can see the fluoroscopic candy sign of the EUS drainage. We can see the stent inserted in the left side, and we can see narrowing at the site of the puncture of the flap with a good drainage inside the stomach. Some prefer. Okay.
Sure. Would you consider to put a small pigtail stent just to...
Yes, this was the question I was asking for. Some professors prefer to put a double pigtail stent to prevent further migration, or despite using G-bore stent with distal large flange to avoid migration inside the stomach, inside the liver. But most experts nowadays don't prefer or don't see advantage of putting double pigtail stent to avoid further migration. What's your opinion, Professor Fauzi? Do you prefer to put a double pigtail stent or not?
Okay, so in my limited experience with this procedure, I'd rather use a 10 centimeter long stent. I know that Boston Scientific produces this stent, so a 10 centimeter partially covered stent would be better, just to be sure that you could keep a larger portion of the stent inside the stomach.
Yes, I agree with you.
With an 8 centimeter stent like this, I would feel safer to insert a pigtail stent. But in this case, it's very nice demonstration. It's very nice position of the stent. Maybe you could leave this way. It's very nice.
Yes, my own experience. We do it without insertion of double pigtail stent, usually with 8 centimeter partially covered stent. Maybe we face the migration just at the opening of the stomach once. Most cases don't have migration, just little distal migration. So I prefer to put a longer part of the stent inside the stomach like this, to avoid, even if the stent migrates a little bit inside, we have still permanent rate. Also, it can give us access for further intervention later on. We can try to cannulate stent to pass the structure itself, or do bridging to the right side to drain the right side if we wish to move the PTD. Do you agree with me?
Perfectly, I fully agree. And let me tell you that you performed the procedure so nicely that gave us the impression that it's easy. But let me tell the audience that it's not easy, like Professor Altonbary made it appear. Okay, so congratulations.
Okay. So we will now move to the FMB as the last step from the lesion itself. We can see here the liver, as do you see the EUS image now?
Yes.
Okay, we can see nicely the left loop of the liver with dilated intrahepatic biliary radicals. Now we will check for this large gallbladder mass. We will see it in a moment. Sometimes we can see the porta hepatis from the stomach, and sometimes we need to go inside the first part of the duodenum with anti-clockwise rotation to visualize the liver and the mass itself. Now we nicely see the left loop of the liver. And moving back, we can see also a little bit of free fluid inside.
So, Professor Altonbary, we've been told that we need to end the session. Maybe you could show us what you're planning to do, FNB, which needle, how many passes, and then we can end the session.
Okay, this is the last step. Now we can see the gallbladder mass. I will point the arrow for the gallbladder mass, this large one. As we have here left loop infiltration, and we have infiltration of the liver. We will perform FMB for this patient. 2 passes. We do fanning technique using slow pull usually as a start. If we don't have enough tissue, we go for suction. Also, the patient is complaining of pain, so we can do also a CPN, although it's not of that much benefit for gallbladder, but we will start by doing FMD. If we have still enough time, I can show first the FMD technique and fanning technique. 22.
Okay.
Do we still have enough time?
I've been told that we must end the session now. So I'm sorry that your procedure was extremely well done. So congratulations once again, and for this very nice demonstration. Second, congratulations.
Thank you. Thank you. Bye.
So we have to move to the next session, session number 5. This session will be chaired by Professor Ibrahim Mustafa, who is professor of gastroenterology and hepatology at Theodore Beers Institute in Egypt. He's a very good friend, so thank you so much. I had some problems with the internet, so I did not have the opportunity to thank the organizers, Professor Ibrahim Mustafa, Professor Mustafa Ibrahim, for the kind invitation. It was an honor to chair one of the sessions of this outstanding, very well organized webinar, live endoscopy webinar by ROEYA. So very good again, congratulations, and thank you for the invitation. So Professor Ibrahim Mustafa, you are chairing the session right now.